Hello, my name is Stuart Wegenka, and today I'm going to discuss insomnia from a psychiatric mental health nurse practitioner perspective. This presentation will cover what insomnia is, why it matters clinically, and how we assess and treat it in a way that is evidence-based but relatable to everyday life. Insomnia becomes clinically relevant when sleep problems persist and impair daily functioning. As PMHNPs, we frequently encounter insomnia alongside anxiety, depression, and trauma-related conditions. It includes more than a night of occasional poor sleep. It impacts the mood, cognition, and daily functioning. Insomnia is defined by persistent difficulty with sleep that results in daytime consequences. Chronic insomnia requires symptoms to be present for at least 3 months. Patients often describe insomnia emotionally. Validating their experience is essential, as frustration and anxiety about sleep can worsen symptoms. How patients describe it is exhausted but unable to sleep, anxiety or dread around bedtime, and a reliance on caffeine. Insomnia is frequently secondary to anxiety, depression, PTSD, chronic pain, medications, or irregular schedules. Addressing root causes is critical. It is rarely a standalone disorder, and it's commonly linked to psychiatric and medical conditions. Insomnia reflects a hyper-aroused brain state. Patients are tired, but physiologically alert, which explains difficulty initiating sleep. This includes elevated stress hormones, state of hyperarousal, and sympathetic nervous system activation. Assessment includes sleep patterns, lifestyle habits, and screening for psychiatric or medical contributors to insomnia. Cognitive behavioral training for insomnia is the most effective long-term treatment for insomnia and should be prioritized over medication whenever possible. It is the gold standard for chronic insomnia. It targets maladaptive sleep behaviors and improves long-term outcomes. Medications may be helpful short-term, but they carry risks. Benzodiazepines are cautiously used due to dependence and cognitive effects. Adjunctive or short-term use: trazodone, doxepin, non-benzodiazepine hypnotics. Avoid long-term benzodiazepine use. Sleep hygiene supports treatment, but is rarely sufficient alone for chronic insomnia. Consistent sleep schedule. Limit caffeine and alcohol. Reduce screen time. Optimize sleep environment. Addressing anxiety around sleep reduces performance pressure and improves outcomes. Normalize occasional poor sleep. Reduce catastrophizing and rebuild trust in sleep. The goal is sustainable long-term sleep health rather than short-term fixes. Insomnia is common and treatable. It is often secondary to other conditions. Cognitive behavioral training for insomnia is the first line, and medications should be used thoughtfully. Thank you for my presentation.